much for the invitation. Before I proceed, can I just confirm that everybody can see me and hear me? Yes? Can you see me and hear me at your end?
Yes, sir, we can hear.
Oh, good. I just wanted to be sure. I've done these things before. I've kept talking and then it's taken a while before the messages got back through that no one can hear me, but this is good. All right. As I said, it's really a pleasure and a privilege to have the opportunity to talk to you at this annual medical conference of the CMC. And I know that we've had very many graduates of CMC come through and work in Australia, and I'm hopeful that there'll be a continued link with you and with us here in Australia. But I have the privilege of talking about the latest advances in targeted therapies, and to do that, what I'll do is share my screen. So again, if you could just let me know that the screen sharing is happening. I'm hoping you can see my first slide. Yes.
So we can see your first slide, sir. Thank you.
Excellent. Okay, I'll go through. All right. So the topic is looking at some of the more recent advances in targeted therapies. And I've only got 30 minutes, and so I'm going to focus very much on ways that we're getting to specific targets on cancer cells and how we're exploiting those targets to try and get an anti-cancer effect. So what will be out of scope for today, although I'm happy to take questions about this later, is going to be immune therapy, which is the other big advance. But I'll talk about molecular targeted therapies, the tyrosine kinase inhibitors, and I'll also talk about developments in antibody drug conjugates, so-called magic bullets, and hopefully provide a good summary for everyone. And I'll try and do it in 30 minutes. I'll try my best. So these are my disclosures. This is where I'm based. I know you've just heard a presentation from Anand Rose. I work with Anand here at the Flinders Medical Centre. We're based in the city of Adelaide in the state of South Australia. And the building I work in, the building I'm in right now, is the building that's on the bottom right corner of the slide. That's the Flinders Cancer Centre. You can see an aerial view of the building. It's the building, you may be able to make it out at your end, with a helicopter pad at the top of it. And that leads into the medical centre itself. And up the hill is the university. And you can see part of the university in the picture there. So this is the Flinders Medical Centre and the Flinders University in Adelaide in South Australia. So I'm going to talk about targeted therapies. So these are the therapies that have progressed on from other cancer treatments that have been developed previously, the chemotherapy treatment principally being systemic therapy. In fact, we had hormonal therapy well before the molecular targeted therapies, and hormone therapies are an example of a targeted therapy when you really think about it. But I'll focus more on the more recent molecular targeted therapies. Some of you may remember this cover of Time magazine that showed imatinib or Gleevec as an example of the ammunition in the war against cancer at the time. These are the bullets. So these are emotive terms, but this is really how these sort of new cancer therapies that were breaking through at that time were being perceived. And these medications were really developed on the back of a greater understanding of the very complex molecular biology that's involved in cancer cell growth and cancer cell metastasis, as our understanding of the various molecular pathways involved in that process. And the schematic on the right is a simplification really of a very complex system involving ligand interacting with the receptor. There's a dimerization process, a subsequent downstream phosphorylation process, an activation of a chain of reactions, ultimately leading to an effect on gene expression, and that in turn leads to an effect on cancer cell growth and proliferation. So an understanding of which processes were important for certain specific types of cancers led to specific therapies for those cancers, and the focus today will be on lung cancer. And this is just a schematic showing you the effect of monoclonal antibodies binding with the receptors, the transmembrane receptors, the ligands binding to these receptors, leading to activation again of these intracellular processes. So we've been getting a lot better at understanding these processes and exploiting these processes for an anti-cancer therapy effect. And the other thing that's obviously improved in the last 20 years is our understanding of the human genome and DNA. In 2003, the genome was sequenced. It took 13 years and cost $10 billion. In 2015, a patient's cancer genome could be sequenced in 2 weeks and cost about $2,000. And these costs are coming down, and I'll talk a little bit about how genomic sequencing of cancers is becoming increasingly important in the way we try and treat patients with cancer in the current era. Now, with lung cancer, we know that there are a range of mutations that are potentially targetable, and this is just a graph showing the cancers and the proportion of mutations that we see. And this proportion does vary very much according to a number of demographic factors and even geographic factors. We know, for instance, that EGFR sensitizing mutations are found far more commonly in parts of Southeast Asia, more commonly in females and males and non-smokers, etc. So it really depends on your baseline. But what we do know is when we're discovering more and more mutations, and this fraction that's listed there as unknown is getting smaller and smaller. We're finding more and more potential mutations. And the reason we're so interested in finding these mutations is that we know that some of them can predict for benefit to these targeted therapies. And this is just an example of a waterfall plot that demonstrates response. The downward bars indicate that the tumor is getting smaller. The upward bars above the baseline indicate the tumor is getting bigger. And you can see here that the majority of patients that are treated with, in this case, it was the first active ALK targeting drug called crizotinib. The majority of patients are achieving a benefit with the tumor reducing in size. So that's the kind of activity that obviously makes everybody very excited about the potential beneficial role of these targeted therapies. This is another example, but the same sort of result. This is entrectinib, which is a tyrosine kinase inhibitor that targets cancers with ROS1 fusions and mutations. And you can see quite a significant response. Again, the waterfall plot showing that almost every patient experienced a reduction in the size of their tumor. So again, these medicines can be very active, and that's what these response rate and these waterfall plots demonstrate activity. Ultimately, we need larger trials that demonstrate benefit in terms of survival to really be able to prove that these medicines are effective, at least in terms of the survival outcomes that we so want to improve in this setting. So I'm going to just talk now about the epidermal growth factor receptor targeting approach, which was the sort of the pioneer of the kind of molecular targeted therapy approach in lung cancer, and just talk about the most recent advances. But I will take you back to the key New England Journal publication in 2004 that was the publication by Lynch and others that demonstrated that these activating mutations in the epidermal growth factor receptor gene predicted for responsiveness to treatment, in this case with gefitinib, in the context of advanced non-small cell lung cancer. So it's not all that long ago. We're talking just over 20 years ago when we had the first reports come through that the EGFR mutation may be a predictor for response to these treatments that were in development. Now, we saw studies like the studies I showed you before with the entrectinib and crizotinib. We saw similar studies with erlotinib and gefitinib and then later osimertinib. Good activity and some significant benefit, and at least we saw a progression-free survival benefit in the advanced disease setting. But the more recent advances with these EGFR targeting drugs come in the application of the EGFR targeting approach in earlier stage disease. And I just want to show you the results of the ADAURA phase 3 clinical trial. It's a trial in which patients with completely resected stage 1B, 2, and 3A adenocarcinoma of the lung, where the cancer had an EGFR mutation, either an exon 19 deletion or an L858 mutation. They were randomized to osimertinib, which they took once a day for 3 years, or a placebo. So it's a placebo-controlled trial with a 1-to-1 randomization. The primary endpoint was to demonstrate a disease-free survival benefit. The population of interest for the primary endpoint was patients with stage 2 and 3A. As a secondary endpoint, disease-free survival was looked at in patients with stage 1B included, and overall survival was a secondary endpoint. So this was a study that showed a significant benefit for those patients that used osimertinib. It significantly reduced the risk of disease recurrence in those patients after surgery. The hazard ratio was 0.2, p-value highly significant. And there was an updated disease-free survival that showed that the benefit was continuing longer term with a hazard ratio of 0.27. So this is really demonstrating a significant reduction in the risk of the cancer returning. There was a significant reduction in the risk of CNS metastases. This is one of the areas where the cancer can return, and that can be a devastating consequence of lung cancer when it affects the brain. So there was a significant difference, and you don't really need a statistician to help you see the difference that you're seeing in those survival curves. So that was impressive. But at least in the initial reports, we didn't see an overall survival benefit. But there was an updated analysis that looked at overall survival in patients with stage 2 and stage 3A. That was that primary endpoint population group, where we did see a hazard ratio of 0.49 in favor of osimertinib. So the 5-year overall survival rate was increased from 73% to 85%. So it has been hard to demonstrate an impact in overall survival in the advanced disease setting, partly through the effects of crossover in all the trials, the randomized controlled trials that have been done. So patients randomized to chemo instead of the targeted therapy would often get the targeted therapy after progression. But this was a study where we did see a survival difference. And so in Australia, osimertinib is available for patients, particularly patients with stage 2, stage 3A, with the mutations, obviously. So you need to be screening for the mutations. And this is a more recent study that showed a similar sort of benefit, this time with alectinib, which is an ALK targeting tyrosine kinase. In this study, patients were randomized to receive alectinib or chemotherapy, as shown in the schematic here. And the alectinib was continued for 2 years, not 3 years. But again, we saw a significant improvement in disease-free survival. A hazard ratio of 0.24 at 36 months. That meant that there were 88.7% of patients who had received alectinib alive without a cancer recurrence, versus 54% of patients who had received chemotherapy. So quite a significant impact, quite a significant reduction in the risk of cancer recurrence. Again, proving that concept that these targeted therapies we know are active in the advanced disease setting, but we should be thinking about using them earlier to try and prevent a recurrence of cancer. We don't yet have survival data for alectinib. This is a very recent study that was presented at the American Society of Clinical Oncology meeting this year. It was actually in the presidential symposium. It was the plenary session. And this particular study looked at using, again, osimertinib for EGFR mutation positive patients. But in the setting of disease that's stage 3 and inoperable, where the standard of care is to give concurrent chemotherapy and radiotherapy. And a new standard came into play 7 years ago, and that was the use of durvalumab, an immune therapy, a PD-1 immune therapy drug that improved progression-free survival and overall survival. But the landmark study was the Pacific study, when a subgroup analysis was performed on patients with EGFR mutations that were entered into the PACIFIC study, that subgroup analysis failed to demonstrate a benefit for immune therapy. And so we think that this particular group of patients may be more immune therapy resistant. And so there was, I think, a need to look at other ways of trying to improve the outcomes of that group of patients. There was an interesting study from China, the Russell study, that did suggest a benefit in using erlotinib alongside chemo and radiotherapy for patients with stage 3 cancer. There was an improvement in progression-free survival. So what followed was the LAURA study, which was a large randomized controlled trial with a 2-to-1 randomization where patients received osimertinib, again at the standard dose of 80 milligrams, 1 tablet a day, compared to placebo. And the study was interesting for a number of reasons. So these patients all had stage 3 disease. They had been treated with chemotherapy and radiotherapy initially. The maximum interval from the last dose of radiation therapy to the commencement of treatment, or to randomization, I should say, was 6 weeks. They were all randomized in that period after the completion of treatment. They had to have had a scan that showed that the cancer was not progressing shortly after the end of chemoradiotherapy. Patients were allowed to have had induction chemo before the radiotherapy, but not consolidation chemo. The majority, though, had just concurrent chemoradiotherapy. The other thing that was interesting is that they really were very keen on looking at CNS recurrence. And so patients were required on the study to have regular MRI brain imaging. It was done at baseline, but it was done as part of the routine assessments that followed in an effort to try and be as thorough as possible in identifying the benefit of using osimertinib in preventing or delaying CNS recurrence. So I went through most of that. So as I said, the majority of patients received concurrent chemoradiotherapy. The scans were done every 8 weeks for 48 weeks. And then 12 weeks after that, there was an MRI scan at every visit. So certainly more than what would be considered standard practice in many places. Getting an MRI scan of the brain is not so easy. But this is what was done as part of the trial. The other thing I should say is that unlike the ADAURA study, where osimertinib was given for 3 years, in this study, osimertinib was continued indefinitely. There wasn't a designated treatment period. It was that the patients could stay on treatment for as long as they were tolerating the treatment. There was no sign of cancer recurrence, and the patient wanted to continue the treatment, and the physician involved was agreeing to continue to prescribe the medication. So some of these patients obviously are long-term survivors, and on the trial they were having ongoing 12-weekly scans to assess progress after 48 weeks. So the benefit, again, you don't need a statistician to see that there's a significant difference here in the progression-free survival favoring osimertinib over placebo. At the 24-month mark, 65% of patients did not have any evidence of progression of the underlying lung cancer, whereas in the placebo group, you can see here that 87% of patients did have evidence of progression, a clear difference favoring osimertinib with a hazard ratio of only 0.16. So quite an impressive difference. And really every group benefited from osimertinib, sex and age, race, smoking history. The type of underlying EGFR alteration didn't really make a difference, and whether they had concurrent chemoradiotherapy, which is almost all of them, or sequential. I don't think that there's too small numbers to really assess that. So really every group seemed to benefit from osimertinib. So this is an interim analysis of overall survival. So this is really where it gets interesting as we sort of discuss the real impact of the drug in this setting, in that this stage at least, and it is early, we haven't seen a difference in overall survival. The median overall survival, in the placebo group is not reached, but really you can't see a difference. The hazard ratio is 0.81. So the argument in using osimertinib earlier in the disease process is that it delays, it might prevent progression, or it might just be delaying progression, which you can treat later with osimertinib. But the real benefit, I think, is in this, that you are seeing patients surviving for longer without brain involvement. And as I said earlier, when you do get brain metastases, you need brain intervention, you need radiation therapy, you may need surgery. These treatments have certain consequences that, as I said before, can be quite significant and debilitating. And I think we're seeing here quite a significant reduction in the risk of brain metastases developing through the use of osimertinib. In the placebo group, 29% of patients, when we look at the new lesions, 29% of those patients with disease recurrence have brain involvement, whereas in the osimertinib group, it was less than 10%. So I think there is a real clinical benefit. I think surviving and knowing that you're alive without cancer progression or cancer activity, hoping that the chemoradiotherapy has cleared the cancer, is, I think, a good thing for the patients. But what we're not seeing at this stage is the overall survival benefit. We may need longer to see that. We may not see that. So that's stage 3 disease. So again, another example of bringing the EGFR targeted therapy forward to try and get better outcomes for our patients. So how can we do better than osimertinib is the next question I wanted to cover. And in discussing this, I'm going to introduce MET, mesenchymal epithelial transition factor, MET mutations. Exon 14 skipping mutations are important predictors of response to tyrosine kinases that target MET, and they occur in about 5% of non-small cell lung cancers, seen in both adenocarcinoma and squamous carcinoma. MET amplifications are less predictive, but can still potentially predict for response to MET targeting. And these are some of the MET tyrosine kinase inhibitors that are out there that are showing activity for patients with MET mutations. And MET mutation can be a mechanism of resistance that develops for patients that are previously responding to osimertinib. So it is worth looking for these mutations in patients that become resistant to the initial TKI. I'm going to focus more on the bispecific antibody amivantamab, but we do have some phase 3 data. And towards the end, I'll talk about antibody drug conjugates. So this is a study that was presented last year at the ASCO meeting, the Mariposa lung study, that looked at using amivantamab plus another tyrosine kinase inhibitor, EGFR tyrosine kinase inhibitor called lazertinib, versus osimertinib alone or lazertinib alone. So in patients with EGFR mutation positive non-small cell lung cancer, they're receiving treatment as first-line therapy for lung cancer. So it's testing the hypothesis that you'll get a better effect if you combine EGFR TKI therapy alongside a monoclonal antibody, which is bispecific. It attaches to both EGFR and to MET. That's what amivantamab does. And the study met its primary endpoint. Progression-free survival was improved. Not as impressive as some of those previous curves I've showed you, but nevertheless, a hazard ratio of 0.7 that was statistically significant, favoring the combination of amivantamab and lazertinib. And we saw a longer duration of response when using amivantamab with lazertinib versus osimertinib. And this is just to demonstrate that the lazertinib did not perform on its own, did not perform inferiorly to osimertinib. It looked to be very similar. So it's just another EGFR TKI. And the interim overall survival did not demonstrate a survival benefit. The hazard ratio was 0.8. Numerically, the amivantamab was better, but that wasn't statistically significant. The issue with this bispecific antibody is toxicity, where you see side effects like paronychia, rash, diarrhea, peripheral edema, fatigue, transaminase increases, low calcium. So there are a number of things that need to be managed when patients are receiving that. And so patients receiving osimertinib often tolerate the treatment really quite well. You do have a progression-free survival benefit. You don't yet see an overall survival benefit, but there's quite a cost to pay, not just financial in terms of toxicity, for adding amivantamab into the mix. So I think it's an interesting study, but whether it is something that would come across for all patients as a first-line therapy, given the safety profile, I think is doubtful. And there is an adverse event of special interest, which is venous thromboembolism, which occurs at a significant rate with this medication. And so the recommendation is that patients commence prophylactic anticoagulation for the first 4 months if you're going to start amivantamab. And what about for patients that have non-small cell lung cancer and the cancer's progressing on osimertinib? Well, this study was a phase 2 study that looked at the combination of that bispecific antibody with lazertinib in that context. And we did see significant activity in continuing the tyrosine kinase inhibitor, lazertinib in this case. It was just switched over from osimertinib, but adding in the bispecific antibody, amivantamab. So we did see evidence of activity, but we really needed a phase 3 study. And this is the phase 3 study that's been presented to see if carrying on with lazertinib and adding in amivantamab is better than what is the standard of care, really, which is chemotherapy in this sort of context. 3-arm study where chemotherapy was the comparator, the standard, and the 2 study arms were amivantamab with chemotherapy, or amivantamab plus chemotherapy plus the TKI. And what we saw here is that the amivantamab arms did significantly better than the comparator, the chemotherapy alone, in terms of prolonging progression-free survival. So this is really as a second-line therapy. My opinion is that's probably where this drug is going to come into play, where you've got selected patients who you think can tolerate the amivantamab, who want to receive more treatment. It may be that amivantamab plus chemotherapy is better than chemotherapy alone. And whether you continue lazertinib or not, we're not quite sure. That wasn't a question in this study. And you get a higher response rate when you use amivantamab, so the bispecific antibody. And the same drug was looked at in the context of exon 20 mutation positive non-small cell lung cancer. That's a less common activating mutation. It's one that is relatively resistant to osimertinib. And so we're looking for TKIs. There have been some in development that still haven't been able to demonstrate superiority over chemotherapy. So chemotherapy was considered and still is the standard first line. So this is a study that compared chemotherapy, the standard, with amivantamab plus chemotherapy, and it did show a progression-free survival benefit for exon 20 non-small cell lung cancer, this time with a more impressive hazard ratio of 0.395. So amivantamab, the bispecific MET and EGFR targeting antibody, may have a role here. Mindful of time, but I'll try and whiz through. The next big target is RET, proto-oncogene gene that encodes for a transmembrane tyrosine kinase that's involved in normal embryonic development. Fusions of RET lead to abnormal gene expression that lead to cancer cell proliferation. Found in only a small proportion of non-small cell lung cancer. It's often younger patients with adenocarcinoma. Frequency is about 1 to 2%. It's not associated with smoking, and this is associated with a high risk of brain involvement. And this is a study that compared a tyrosine kinase inhibitor that targets RET, sulpicatinib, to the standard of care really for these patients, which is chemotherapy plus or minus immune therapy. And what we found is a significant benefit in favor of sulpicatinib over chemotherapy and immune therapy. Curve on the left includes those patients that received immune therapy. curve on the right includes all the patients, including those that received chemotherapy alone. But either way, you see a significant PFS benefit with hazard ratios of less than 0.5, favoring selpercatinib. So another molecular targeted therapy that's proving to be more effective than chemotherapy. The response rates are higher with selpercatinib compared to chemotherapy. And again, we see an improvement in intracranial outcomes, a higher response rate in the brain, and there's a lower rate of disease progression within the brain in those patients that received selpercatinib. Another molecule that's coming through is, or molecules, I should say, molecules that target KRAS, particularly KRAS with the G12C mutation. This is data from a study known as Crystal-01 that looked at adagrasib in patients with previously treated non-small cell lung cancer. Most of these patients have received chemotherapy and immune therapy. And again, you see the waterfall plot that shows activity. That's really what it's showing, a significant kind of response rate. And this is the result of a randomized controlled trial that compared another G12C targeting drug, sotorasib, against docetaxel in the second-line treatment setting for patients with advanced non-small cell lung cancer, and there was a benefit in the PFS favoring sotorasib. Maybe not so impressive, but it was statistically significant. PFS at 12 months was only 10% with docetaxel, and it was 24% with sotorasib. So these medicines are coming through, and there are more studies ongoing that are looking at using G12C targeting drugs versus chemo and immune therapy that may come out to show more benefit. Finally, I'm just going to talk about the new kids on the block, which is antibody drug conjugates. You may or may not have heard of these drugs, but they're really the medicines that are commonly being kind of referred to as magic bullets. And it's magic in that it's an attempt to try and get chemotherapy into the body directly to the tumor cell. That's really what antibody drug conjugates are. The antibody drug conjugate is made up of an antibody with a variable portion and a fixed portion. The FC portion has a linker that attaches a cytotoxic payload. These are the terms that are used for these bullets. And so you are attaching a cytotoxic medication to the antibody. And the key here is that the antibody is one that will bind to a pre-specified antigen that you hope is only on the area that you wish to target. So it's really an antigen that's only going to be found in the cancer, and that's the principle. So you're bringing in the medication directly to the tumor. And there are a few that are in development and some that have come through phase 3 studies that are showing significant benefit. And there's a list of some of them there where the target is HER2. There's some that target TROP2, and I'll talk about some of these. Some more recent ones targeting Dectin-2, but there are a range of targets that are being looked at and drugs that are being developed to try and treat various cancers. And this is another schematic that just sort of gives you an idea of the range of potential receptor targets and drugs that are in development. And I can tell you that this list is growing kind of every month, I think, as ADCs are coming through. These are some of the warheads, the drugs that we're looking at. They're mainly topoisomerase inhibitors or microtubule destabilizers. Most often. Trastuzumab deruxtecan is one of the first to show activity in lung cancer. So again, this is another schematic. It shows you that you can have more than one linker, more than one kind of warhead on an antibody, and that ratio of warheads to antibodies is one of the things that's looked at in terms of the activity of the drug. The linker itself may be cleavable, may not be cleavable in certain environments, and that sort of relates to the activity of the ADC as well, and that can be manipulated. So there's a lot of chemical engineering that goes into these drugs. HER2 positive lung cancer is not that common. It's less than 5% of lung cancers, but they're have been studies that have looked at using trastuzumab deruxtecan in advanced lung cancer with that's associated with HER2 or an ERB2 mutation. And you can see that, again, you've got waterfall plots that are showing significant activity. This study looked at 2 different doses of the drug, and the lower dose seemed to be as effective, and there was less in the way of pneumonitis, which is one of the toxicities that we're worried about with this particular antibody drug conjugate. So after you see activity in these sort of phase 1, phase 2 studies, you need to move on to a phase 3 to see if it really is beneficial. The setting here was second-line non-small cell lung cancer. The comparison is Dato-DXd. This is a TROP targeting antibody drug conjugate with deruxtecan as the chemotherapy, the warhead. Datopotamab is the antibody that attaches to TROP, which is found mainly on tumor cells. Docetaxel is a standard second-line chemotherapy treatment. And this study did show a progression-free survival benefit in favor of the antibody drug conjugate with a hazard ratio of 0.75. You see that most subgroups benefit, but this is where the subgroup, the forest plot analysis is really quite insightful. You can see that the squamous histology groups seem to do worse. And when you look at the PFS and you break it down by histology, you can see that the benefit of Dato-DXd was restricted to patients with non-squamous non-small cell lung cancer or adenocarcinoma, whereas there was no benefit, maybe even harm, in those patients with squamous histology. The study allowed all comers in. So you can see a clear difference by histology. The overall survival did not differ between the two. So this is an interim result, but we haven't seen a difference in overall survival. And there were a number of adverse events of special interest with these antibody drug conjugates. I mentioned pneumonitis earlier, stomatitis, ocular events. It's even though it's chemo, and you can get chemo kind of side effects, you get different side effects as well that you need to be across. This again is just showing the activity that I talked about before. So this is another antibody drug conjugate, sacituzumab govitecan, again a topoisomerase inhibitor, again TROP targeting. So it's kind of similar to the previous drug. But this drug, again, was compared to docetaxel in the second-line setting. And what we saw here was the primary endpoint of overall survival for this study just wasn't quite met with a hazard ratio of 0.84 and a p-value of 0.0534, unfortunately, so not quite there. The response rate also wasn't really higher with sacituzumab govitecan, so this was a disappointing result for a TROP targeting antibody drug conjugate. It was hoped that there'd be a more obvious benefit there. So the studies are ongoing with ADCs, and there are a number of emerging targets, new ADCs that are coming through. This is just my final slide that just talks to a number of other targets of interest. NTRK you've probably all heard of. Again, very uncommon, but there are tyrosine kinase inhibitors that are very active in treating cancers associated with an NTRK mutation. There's a group of pan-RAS targeting molecules that are coming through. There continues to be an attempt at BRAF targeting, HER3, Nectin-4, et cetera, and there are more. So it's certainly a very busy field. I think I've gone just a little bit over time, but I'm very happy to answer questions if there's time enough for me to do so. Thank you, everyone. Thanks for listening.
Thank you, sir. Now we will go on to the question and answer session, handing over to the chairpersons.
There are 3 excellent talks. Thank you, Dr. Chris. I think you tried to cover a lot of topics or a lot of molecules within a very short time. My question to you is, do you see a future where after doing a whole genome sequencing, a patient can get a tailor-made molecular-based therapy rather than the current chemotherapeutic regimens?
I think potentially there'd certainly be a role for genomic sequencing to try and identify targets for which we have effective medicines. It's certainly important in research as we try and better understand cancer. But there are other treatments that probably don't rely so much on, at least at this stage, in terms of what we know about genomic alterations, probably don't rely so much on the mutation profile results. And I'm thinking here about immune therapy and even chemotherapy. I think those treatments still have a role to play. And right now, we don't really need the full genomic panel to identify patients that are suitable or not suitable for immune therapy. The only predictor that we really have at the moment for immune therapy efficacy is PD-1 expression on the tumor, and we also have evidence through, you can get this through genomic profiling of microsatellite instability or mismatch repair deficiency. So if you see those things, you usually are talking about a cancer that has a much higher rate of progression. But most of those individual mutations don't come into play. They can be factors. As I said earlier, those with EGFR activating mutations may be less likely to respond to immune therapy, but they're not usually cold, hard, black, white predictors. So to answer your question, I think getting the mutation profile can be useful. I think you need to get as much information as you can to try and get the best treatment plan for your patient. But there are some treatments that we currently have available that don't require those broad mutation panels yet. Yeah.
Thank you. Thank you, Dr. Chris. My second question is to Dr. Jefferson. You have pointed out, there are a lot of patients whom we think is COPD, and suddenly after doing a PFT, I see there is reversibility. So my question to you is, would you have, like, if I see a lung function test with reversibility, can I start ICS immediately, or should I do more tests like getting the eosinophil levels and other markers to see for response?
The subsequent evaluation will always be driven by the clinical history of the patient. At the end of the first visit, what would you put first as diagnosis? Is it going to be asthma, or is it going to be COPD, or is it going to be a overlap symptoms? So at the end of my clinical evaluation, I will probably go on to write a probable asthma or a probable COPD diagnosis. Then when I review my spirometry, that's going to aid me in confirming the diagnosis a bit more. So if I get a person who has a clinical history of COPD, but the spirometry is somewhat reversible, and there is definitely a severe obstruction, because in severe obstruction, even COPD, you can expect some amount of reversibility. I will still treat him as COPD. Of course, we will be having some, when there's a doubt, we can always go for a pheno or blood eosinophils, and if that also concurs, you can just give bronchodilators.
Thank you. Thank you, Dr. Jefferson. So the other question to you is, any LABA alone inhaler in the market? Sir.
Yes. We don't have LABA alone inhalers. It's always available in combination with the main products.
So the other question is to Dr. Chris. The question is, lung has become a very interesting cancer, lung cancer. So TKIs are available in India, but financial access is a common problem because of the cost. Are there any studies show that a reduced TKI dose or increased spacing is possible?
The TKIs can be very active. Those waterfall plots demonstrate major activity, tumor reduction, tumor shrinkage, and you can get tumor shrinkage at lower doses. I don't think the story here is the same as the immune therapy story. I think many people in the room there will be aware of research that's coming out of India, actually, that shows that you can get a significant benefit from drugs like pembrolizumab or nivolumab at 10% 15-20% of the recommended doses. So the immune therapy effect of the immune therapy drugs can be induced at a much lower dose. And as you know, it's not the immune therapy itself that's going in and having the anti-cancer effect, it's the response that it induces. So we are seeing studies coming out of places like India. These are not coming out of pharma for obvious reasons. They're not sponsored studies, and they're not coming out of other parts of the world, that are showing that immune therapy can potentially be similarly beneficial at much lower doses than the current recommended fixed doses. But with tyrosine kinase inhibitors, these drugs have shorter half-lives, have a shorter duration of action. I think there will be a threshold. Now, I don't know what that threshold is, so I can't really give any firm advice on the wisdom of starting at, say, a 20-25% dose or a 50% dose even. But I would expect to see an anti-tumor effect at substantially lower doses than we currently give. The other thing is there are some toxicities for some of them, and some of the tyrosine kinase inhibitors need to factor in treatment breaks. Maybe not so much the ones that we use in lung cancer, but in other cancers where we give the treatments for 3 or 4 weeks and then we have to stop the drug for a couple of weeks. We don't seem to see a loss of cancer control in doing that. So that could be another cost reduction strategy, and that is that you give the recommended dose, but you give the dose for 2 weeks or 3 weeks and then have a week off. That's effectively a dose reduction of 20 to 30%, but it hopefully it won't have a negative impact on cancer control. And some of the recommended doses, I know this to be so with ALK targeting with lorlatinib, are considered to be poorly tolerated by patients. And so there are some studies that look at starting some of these doses at lower doses, getting a response, and sometimes increasing the doses if you can, if the treatment's well tolerated. But in a situation where it's hard to fund the medicine, it may well be prudent to just continue the lower dose. So I think to answer your question, yeah, you can probably give a lower dose and get a response. How low is too low? I don't know. But I'd expect for most of these tyrosine kinase inhibitors, doses of somewhere between 50 to 75% of the recommended full dose will probably still be active and effective.
This comment is regarding the talk by Dr. Anand Rose. Excellent talk, well done. We learned so many things from your talk. So what do you think the potential for lung cancer screening or HRCT in Indian scenario? But during the COVID pandemic, even before the patients, and not in CMC, but outside, even before they get to go to a doctor and get the RT-PCR for a COVID test, they would have visited a CT scan center and done a CT scan, and they will be sitting in front of you, coming to you with a CT scan report. Doctor, now you treat me. So CT scan is widely available in at least in many parts of southern India.